Assalamu alaikum wa rahmatullah. So thank you for joining this session. As the society, inshallah, will be registered, we'll try to do more sessions. And this session is according to the request of some of our colleagues. So the care of sick child is actually a very long session. It's more than 300 slides. So we will do it on sessions, and the speed of the session will be based on the your digestion and if there is any questions or not. So consider this session as chit chat or bi-directional. So you can ask questions while I'm doing the session. It would be more understandable, and we can do 1, 2, 3, 4 sessions, depend on how we go. So I will start sharing my screen. And I already start recording the session, just in case anybody want to review it later on. Questions? If somebody has a question? No? Okay. So, what is treatment of acutely ill child? If you can kindly mute yourself, that would be great. So, any problem in the body that end in the cardiac arrest and or heart stop beating, and it results from same process, whatever the trigger. So we have either respiratory failure right away, either because sudden respiratory arrest or respiratory distress leading to respiratory failure. Respiratory failure cause cardiopulmonary failure, or we have circulatory failure lead to shock and then lead to cardiorespiratory shock. Or we don't have circulatory respiratory, we have a cardiac, and the cardiac shock is also considered circulatory, but we have sometimes sudden cardiac arrest that lead directly to cardiac arrest without causing cardiopulmonary failure. And this is very unlikely in children, and usually resulted from ventricular fibrillation or ventricular tachycardia. So respiratory failure without respiratory distress usually occur when there is obstruction, sudden obstruction of the upper airway or respiratory tract, or sudden pause of respiration. You have sudden apnea for some reason. While the respiratory problem, it caused some respiratory distress and gradually resulted in respiratory failure. Now, this is the algorithm approach used by pediatric advanced life support, and it composed of initial impression, and initial impression making a decision whether the child is responsive, but he's not breathing, whether the child is responsive or unresponsive. If the child is unresponsive, is either unbreathing or only gasping, and we'll talk about all these. I'm sorry, I'm being interrupted by people coming late. So when the child is unresponsive, you should shout for help activate whatever code is in your hospital. After you see the child unresponsive and you call for help and activate the alarm, then decide about the circulation. Is there a pulse or there is no pulse? If there is a pulse, then start ventilation. If there is no pulse, then you have to do CPR. Now, before we use ABC, but now recently has been changed to CAP. And the reason we start to recognize the importance of cardiac resuscitation in pediatrics. If there is pulse and you started ventilation, now you check the heart rate, whether the heart rate is more or less than 60. And then you go with the resuscitation. Now the resuscitation, as usual in NRP, same. You evaluate, you identify, and then you intervene. Now this cycle should be always 30 seconds. So let's start in details how we can do the algorithm. When you do the assessment of pulse and you do general assessment, you should be quick, and you should start assessing the baby while you're walking toward the patient, because you have a visual and auditory observation. And the first thing you identify whether the child is unresponsive or responsive. And if he or she is responsive, you have to decide, is she irritable or alert? So conscious, and then breathing. Is she breathing, gasping, or not breathing? And if she is breathing, is there a pulse or there is no pulse? So this is the usual sequence when you assess your primary assessment. When you look at the color, when you do initial assessment, you have to decide there is change in color or not. And when you decide, you have to decide, is there a cyanosis, is there a pallor, or there is mottling. When you assess the consciousness, you have to recognize that any of the following can disturb or change the consciousness. If there is hypoxia, there is no oxygen, or there is hypoglycemia, there is no substrate, or there is a brain trauma, or the brain is not functioning for any reason. If the child is breathing, then you have to diagnose whether there is abnormal breathing or not. When we say abnormal breathing, whether the child is using the accessory muscle, if there is any extra sound, and what is the breathing pattern. Now remember, the algorithm from the initial assessment until the final management is composed of 3 steps. Primary assessment, and we've talked about it, conscious, responsive, unresponsive, breathing, unbreathing, pulse, no pulse. And then secondary assessment, and lastly, the diagnostic test. And again, this evaluation composed of 30 seconds, and then you have to re-evaluate each passing period time and each action you take. When we say the patient is pale or mottled or have changing color, we mean there is poor perfusion or there is poor oxygenation or both of them. When we say the child is flushed or red, ruby color, we mean that there is either fever or toxin cause peripheral dilatation and changing the color. So the whole pulse is composed of, as we say, primary assessment, secondary assessment, diagnostic test. Each of them composed of evaluation, identify, then do the action or intervention, and then repeat the cycle. So when we evaluate in the primary assessment, we do it as A, B, C, D, E, F. And we assess respiratory, cardiovascular, and neurology system. When we do the secondary assessment, we use ample or focused history and focused examination. When we talk about diagnostic tests, we talk about laboratory, radiology, and if we need other tests. So I'm gonna rub it a little bit more. So we have initial impression, conscious, breathing, color. If the child is unresponsive, call for help, activate alarms or your code. If the child is unresponsive, then check for breathing. Is there breathing or not breathing? If there is, the child is breathing, then check for pulse. If there is pulse, start positive pressure ventilation. After you start positive pressure ventilation, check the heart rate above or below 60. If there is no pulse, go right away to CPR. So this is your initial. And all your action is composed of evaluation, identify, intervention. The evaluation depends on the stage of it. You are in the primary assessment, you are in the secondary assessment, or you are in the diagnostic test. So the primary assessment composed of A, B, C, D, E, F. Secondary assessment is ample, and the diagnostic test composed of laboratory, radiology, and diagnostic test. Any questions so far?
Yes. Can you explain ample, please?
Ample is abbreviation of focused history. So A, not for something, M not for something, P meant something. So it's an abbreviation, and we will talk about it when we reach the secondary assessment. It's a focused history. So if there is any history of allergy, medical history, pregnancy, something like that. Any more questions?
Thank you.
Okay. So after you did evaluation, now you identify the problem. When you start to identify a problem after your evaluation, whether you are in the primary or secondary, or you are in the diagnostic, you assess or you identify as usual. You say respiratory problem, cardiovascular problem. When you say respiratory problem, you have to say, is it upper airway or is it lower airway? Is it lung tissue or it's the brain not breathing? Are we having respiratory distress or are we having a respiratory distress or are we having a respiratory failure? When you identify cardiovascular, you identify hypovolemic shock, distributive shock, cardiogenic shock, obstructive shock, or it's a multifactorial shock. And when you diagnose the shock, the shock is compensated or not compensated? And is it hypotensive shock or not hypotensive shock? Are we in cardiorespiratory failure or are we in cardiac arrest? So, and we will talk about this all detail. Sometimes this problem came or present in combination, or sometimes one lead to another. And sometimes you are not certain about the type and about the severity. So again, it's a primary assessment, secondary assessment, diagnostic, each composed of evaluate, identify, and then intervene or act. When you evaluate, identify, you make it respiratory or cardiovascular. and then you decide upper or lower, lung tissue or brain disordered of controlled breathing. Is it failure or arrest? When you say cardiovascular, what's the type of shock? Is it compensated shock or it's hypotensive non-compensated shock? Do you have a cardiorespiratory failure or we have this, the heart is being arrested? There is a sole problem or a combination of problem? And remember, sometimes one lead to another, and sometimes you are uncertain about the type and the severity of the problem. Any question? And please ask question, because I will start ask question now. So how you intervene? Now you identify, you evaluate, now and then you identify, now to intervene. How you intervene? For respiratory, you position, you give oxygen, you provide ventilation, maybe nebulization. For cardiovascular, you do CPR, you check the, you apply EEG, ECG to monitor, you may need pulse oximetry, you need IV or intraosseous, you might need boluses. You addition intervention, you activate your alarm, you might need the crash code that you're using for ventilation, you might need to activate cardiac arrest, and so on. So again, evaluate 3 types, identify cardiac, respiratory, upper, lower, and the type of shock, and then you act respiratory, cardiovascular, and others. Any question? So again, it's evaluate, identify, intervene, and repeat the cycle until stable. And then the cycle would be to repeat it every 30 seconds and before and after any intervention. And when you identify the problem, you have to decide, is it life-threatening, need immediate action, or not life-threatening, you can postpone it after you manage all the life-threatening conditions. So what are the life-threatening conditions during your evaluate, identify, intervention cycle? Absent or agonal respiration is life-threatening. Respiratory distress is life-threatening. Cyanosis is life-threatening, and change level of continuousness is life-threatening. Any question so far about the algorithm? Now remember, when you do, you need to repeat after each intervention. You need to repeat when condition change, improve or deteriorate, and after each cycle of time. So let's go to our primary assessment. Remember, we said the primary assessment is A, B, C, D, E, and it is a cycle composed of, or a chain composed of pieces. So the cycle will not complete it until all the phases are made and you have a complete cycle, A, B, C, D, E. Remember that we have primary assessment, secondary assessment, and diagnostic test. So let's start with the first part of the primary assessment, which is the airway. So when you assess the airway in a sick child, you just need to say, is it patent or not patent? And then you need to decide the movement. Is it abdominal wall movement or chest wall movement? And if you see a movement, there is air moving, so having effective ventilation or not. So you have to listen to the air movement, or what we call it, the breath sounds. So patent, not patent, moving, not moving, air moving or not, then you have to decide, you have to diagnose the airway. So the airway, you say clear or not clear, but maintainable, the child can maintain, or they are not maintainable, you need to help them. Any questions so far? So remember, it is a sick child and you don't need to take time. So when you assess patent or not patent, moving the chest and or not, is it only the chest or the abdomen? And listen to the sound. And then you decide. 3 diagnoses for the airway. Clear, maintainable, or not maintainable. What does clear mean? Mean open and not obstructed. What's maintainable mean? Can be open by simple measure, such as head tilt or chin lift or positional. Not maintainable may mean need advanced airway, such as endotracheal intubation. Any question? Okay, so what are the simple measures to keep maintainable airway? The first is position of comfort, which is head tilt, chin lift position. If there is trauma of the child, we do C-spine injury position. Usually when we have C-spine injury or we have infant, we use jaw thrust. We have to avoid hyperextension, avoid suctioning the nose, avoid suctioning or oropharynx. And I know there is a train to suction, but please remember that suctioning is not part of resuscitation. It is completely unnecessary. And if I am there in resuscitation and you suction, you will be in big problem, including I won't allow you to work with me again. So no suctioning. Suctioning delay resuscitation. Suctioning causes bradycardia. Suctioning causes bleeding. Suctioning causes trauma. Suctioning causes distress. Suctioning causes pain. Suctioning causes increased irritability and GI problem in future. And suctioning take important food from the child. What is the benefit of suctioning? Zero. No fun, no benefit.
Excuse me, Dr. Yahya.
Yes, ma'am, tell me.
Are you talking about suctioning of the stomach or the oropharynx and nose?
Oh,
you
don't suction anything. You just clear the airway. There is indication of suctioning is 2. If you use the simple measure and you cannot keep your airway maintainable. So what does that mean? There is chest movement, there is abdominal movement, but there is no breath sound. So you have some obstruction. You are allowed to suction. Second, you want to intubate and you don't see, you suction. Otherwise, in suction are not indicated at all. Neither the nose, nor the mouth, nor the abdomen. The abdomen is at all. Suctioning the abdomen is just barbaric action. There is an only used by desperate people who don't know the resuscitate. Suctioning are not part of resuscitation.
Okay,
now, sometimes you need to empty the stomach if you want to do surgery and you are not using cuff tube. And the stomach is full with food that you think it might go back to the resuscitation, to the airways. You know, that's putting feeding tube for a drainage, not suctioning. Because if the abdomen is full and it will push the content to the airway, then you don't need to suction. You just put the tube for free drain. Sometimes, some condition, we put feeding tube and we put intermittent suction. Sometimes we put continuous suction. It depends on some surgical conditions. Sometimes we have congenital diaphragmatic hernia. We need to put a feeding tube, but we don't need to suction. So suctioning, again, is not part of resuscitation. Any question?
دكتور ريحة.
Yes, sir. Tell me.
دكتور بلا زحمة مسألة أنه الطفل صار عنده pulmonary hemorrhage خلال الريسستيشن شلون راح
Yes.
يكون
Why there is pulmonary hemorrhage? See, when there is pulmonary hemorrhage, what happened is during resuscitation, now we are deviating from primary assessment, but it's okay, I will answer the question. So remember that in the lung, you have two parts. You have the alveoli or the pulmonary system, and you have the vascular system. These systems should be identical. So let's say if the vascular system is 1 centimeter and your respiratory or pulmonary system is 0.5 centimeter, you still 0.5 centimeter and not in contact with the vascular system.
Yes.
And that's why that's 0.5 centimeter will goes from artery to the capillaries to the vein. That's what we call it shunt. This is the cause of the bleed. So any procedure you do to cause that, it will lead to bleeding.
Yes.
You got it? So what are these examples? Sometimes it's a combination. Infection that cause increase pulmonary flow. PDA, under PEEP.
Yes.
Sudden change of pulmonary mechanics. And that is an example when we give surfactant. Now, some people, and in some book written that surfactant cause pulmonary hemorrhage, which is incorrect. Surfactant never cause pulmonary hemorrhage. The way we give surfactant cause the pulmonary hemorrhage, because again, the pulmonary circulation should match the pulmonary system. If you do any to cause discrepancy or less match, you cause the pulmonary hemorrhage. Sometimes it's environmental. So when it happens, you just need to restore it. Whatever you did, you have to restore. So if you tell me why surfactant, it's the way we give it. So there are many ways we give surfactant. I saw people, they think they know how to give surfactant, but they don't know. So in, like if you ask me how many times you saw surfactant cause pulmonary hemorrhage, 0. Over 25 years of neonatal service, I never seen surfactant. But when you give surfactant with me, you are actually, you have to be very disciplined. You are in a military service. You can do whatever you like. So,
دكتور
yes, sir. Go ahead.
اذا احنا بدنا نسوي ريسستيشن والطفل يحتاج انتيوبيشن اول ما يشد يرجع لنا بلاد فهذا هو اللي يصير عندنا فانا بدي اسال عن الطريقه مال السكشن شلون تكون ايش قد البريشر اللي نسحب به
no suction even if there is a bleed unless the bleed inside the ATT and you are obstructing that. So once you have a bleeding, you don't suction it. You don't suction the blood unless the blood inside the ATT and you cannot ventilate. So you're showing sign of obstruction or you are increasing expiratory phase. You have prolonged expiratory phase, or in the loop, the volume pressure loop, you have expiratory hysteresis. If you know what's hysteresis, if you saw. And if you have auto PEEP, all these are sign of, or you see high CO2, or your system is alarming obstruction, your ventilation. In that situation, you suck. So what are the pressure?
Sorry, doctor. Sorry,
Go
doctor.
ahead. Yes.
How can we differentiate this is a pulmonary hemorrhage, not upper injury, upper airway injury?
Either way,
Thanks.
either way, you don't suction. You don't suction unless you are obstructing the upper the breathing. So you have, if you have ETT, you will know you are obstructing by different ways. And if you are not intubated, you will see abdominal or chest movement, but there is no air entry. There is no sound. So in that, you suction. Now, what are the pressure you use to suction? You suction the nose and the mouth. You don't suction anything else. You don't go to the stomach. Now, what are the force you use? The lower, the better. But I would say between 80 to 100 centimeters of water.
Thank you. Thank you. Clear. Thank you.
Questions? Okay.
شكرا دكتور.
Yeah. When also your simple measure is observed if you have foreign body. So how we know the fact? You suspect that there is a foreign body, and also you see that, you know, the upper airway obstructed, you know, by blood, as you said, by any foreign object or whatever. And one also simple measure, we can use the simple airway such as nasopharyngeal airway or oropharyngeal airway. These are all called simple measure of opening upper airway. When first time you diagnose it as maintainable. Now, when we have foreign body, now you'd have to decide how to manage the foreign body, whether you are below 1 year or above 1 year. If you are below 1 year, you put your elbow between the two legs of the child, and your fingers support the face to maintain the position of the baby. And then you do 5 back slaps, or you put it on other way, your baby will be on the back, you do chest thrust, and we'll talk about it in detail. If the baby is more than 1 year, you do abdominal thrust by holding the baby by your hand on the abdomen, and his patuk or his bag is on your abdomen, and then you do the abdominal thrust. Any question about the simple measure to open a maintainable airways? Remember, we said how we assess patent or not patent, moving or not moving, if moving abdominal or chest. Listen, if there is entry or there is no entry. Now you decide, clear, no intervention, maintainable, you do simple measure, or not maintainable, you need advanced measure. Question? And if you think I can stop anytime if you guys want. Now, when we talk about advanced airway, to open unmaintainable airways, we're talking about intubation through ETT. We need sometimes CPAP, continuous positive airway pressure. We need laryngoscopy, and sometimes we need cricothyrotomy, which is the emergency subtype of the surgical thyrotomy. So cricothyrotomy is opening the airway by a needle or by surgery just below the larynx. Now, whether you are clear or maintainable or unmaintainable, the correct position is always needed for airway. So now we've decided, this is our initial assessment, our primary assessment, and we are going by A, B, C, D, and E, and now we reach to B. So remember A, patent or not patent, chest moving, abdominal movement, sound and air entry or not, and then decide clear, maintainable, unmaintainable. Now we go to breathing. So in breathing, we check respiratory rate, respiratory effort, chest expansion, air movement, lung and airway sound, and we check the saturation of oxygen by pulse oximetry. And of course, if we have, we can measure the local tissue oxygenation by NIRS, but I'm not going to speak about NIRS. Okay, so let's start with the respiratory rate. Now, this is rough numbers. This does not mean these are the normal, but these are the rough numbers of respiratory rate with the age. So if you are less than 1 year, roughly you are between 30 to 60. And if you are a toddler, preschool, you are, if you are a toddler, you are from 1 to 3 years, your rate is 24 to 40. If you are preschool, your rate 22 to 34. If you are a young child, then 18 to 30. And if you are old child or adolescent, you are somewhere between 12 to 18. So it's simple, but you need to use your judgment call and subjectivity when deciding about respiratory rate. Now, how we count the rate? We count over 30 seconds. Not like the NRP, we count over 6 seconds or 10 seconds. Here we monitor over 30 seconds and we multiply it by 2. And you can monitor it many times. Yes, Dr. Sarmat, ask me.
Dr. Yahya, sorry, I think the slideshows are fixed on the A still. We are in B, right? Yeah.
Is it?
Yep.
Everybody is A?
Yes, it's still an A.
Yes, still an
Okay. Let me stop and start again.
Thank you.
I don't know why that happened, but I think it's a technical issues. Is it now at the breathing?
Yes.
Yes.
Okay.
Yes.
So we finished primary assessment. We said primary assessment is A, B, C, D, E. And we remember it's a cycle composed of pieces. And the second part is, you remember what we did for the airway now is breathing. So in breathing, we check the respiratory rate, respiratory effort, chest expansion and air movement, lung and airway sound. And then we check the oxygenation by pulse oximetry or systemic oxygenation or arterial oxygenation. But also we can check the venous or local tissue oxygenation or regional oxygenation by NIRS or near infrared spectroscopy. So this is I was talking about the respiratory. Do you see now the respiratory rate?
Yes.
Okay, great.
Yes.
Now we said when we check the respiratory rate, we check over 30 seconds and multiply it by 2. We can check it many times. Or also we can use the monitor to monitor the respiratory rate. Now, but always when you use the monitor, consider the artifacts. Now, we always, when we do a primary assessment, we don't need to be specific. We just need to say, are we below 10, or we are hypoventilated, or we are apnea, or we are above 60. So that is the reason for counting respiratory rate. You don't need to say your specific numbers. And need to consider the fast breathing causes such as fever and pain. I know most of you not dealing or not considering pain and resuscitation, but I wish that those who resuscitate a baby without appropriate considering the pain and the stress we are causing, I wish that I have them feeling what the baby feels during resuscitation. Also, metabolic acidosis can cause tachypnea, diabetic ketoacidosis, dehydration, sepsis, heart failure, anemia, some congenital heart disease that are cyanotic, and some medication. While other causes of bradycardia, when the baby is fatigued. So if the baby is too distressed or upper airway obstruction and trying to open airway, they will fatigue soon. Or if we have pneumothorax, they will fatigue. Or if they are so tired, or because of the medication or addiction, there are many causes that cause muscle fatigue and stop breathing. If we have central nervous system depression, or we have injury, infection, hypothermia, medication, severe anemia, some cyanotic congenital heart disease, and remember, not breathing or bradyapnea or the respiratory rate less than 10 is a very serious ominous sign. Okay, so when the baby is below or the child, the respiratory rate below 10, it's either apnea, and apnea means either cessation of breathing for 20 seconds or less than 20 seconds, but associated with brady, desaturation, pallor. And when we have apnea, we divide it to central, obstructive, or mixed. So the obstructive usually end in mixed, and central usually remains central. So there are always confusion about something called gasping. And people don't know what is gasping. Sometimes people use the word gasping about hypoapnea or hypopnea, but gasping means breathing that is irregular and there is no effective breathing. That's mean there is chest movement with or without moving air, but there is no gas exchange. That is gasping meant. Mostly there is movement, but there is no movement of air and there is no CO2 and oxygen exchange, and the baby ended in respiratory acidosis and hypoxia. So that is the meaning of gasping or agonal gasping. Agonal mean very, very serious. So we assess the A, B, and then we finish with the respiratory rate. Now we go to the respiratory effort. So there are a couple of people that was listening to me, and I know there is confusion between upper and lower airway. So I want to ask anybody who does not know what is the meaning of upper and lower airway? And if you think you know, can you tell me what is upper or lower airway? However, you should not the person who heard that from me. Anybody knows the difference between upper and lower airway? Anybody? Or even those who listened to me before, what is upper airway?
Dr. Yahya?
Yes, sir. Tell me.
So the upper airway is when there is it's depends on the difference in the pressures. So
okay, but what is upper now? Before you explain, what is upper airway?
Upper airway is above the thoracic inlet.
Okay.
And the lower airway is below the thoracic inlet.
And what is thoracic inlet?
It's when there is the difference in the pressure start. So
yes. So in the upper airway, there is positive atmospheric pressure.
Yes.
While the lower airway, there is negative intrathoracic pressure.
Yes.
Yes, so that's the upper airway. It has nothing to do with anatomical position of the airway. And the reason why we differentiate upper airway, because the pathoclinical manifestation is different. Because the pressure to move from one point to another point, from A to B, B has to be less than A. And therefore, when we start breathing, the point A, which is in the atmosphere, and point B, which is inside your mouth, should be less than A. So the air moves from the atmosphere to your mouth. And to do that, you need to expand your airway to drop the pressure in point B inside your upper airway. And because your pressure and the upper airway has to be, the point A pressure has to be above point A. And that's mean the pressure outside the upper airway is more than inside. And therefore, the diameter of the upper airway will be smaller. And therefore, if there is upper airway problem, it will be more severe in that phase because the pressure outside is higher than the pressure inside. Now the pressure has to move, or the air has to move from upper airway, which is now point A, or let's say point B, and then need to move inside the chest, which is point C. So the pressure in point C has to be less than the pressure in point B, or point B pressure has to be above point C. To do that, the chest expand and the negative pressure inside the chest be less, and therefore the pressure at C point become less than B, and then the air move from upper to the lower. And therefore, because the pressure at C is low, then the airway will expand. So the diameter of the lower airway will be the maximum during inspiration. And therefore, if you have lower airway problem, it will not manifest at the beginning during inspiration. Now the pressure has to move from C to B. And to do that, the pressure inside the chest has to be more than the pressure inside at point P in the upper airway. And to do that, the negative pressure has to increase and chest has to collapse. And because the chest is collapsing and the negative pressure inside chest become positive, then the airways, which is the lower airway, will collapse because the outside pressure become less than the inside. And therefore, in the lower airway, the problem, it will manifest at the beginning during expiration. Now the pressure has to move from point B, which is upper airway, to point A, which is the atmosphere, which means the pressure at point P has to be higher than the pressure at point A. And therefore, because the pressure is higher inside than the outside, then the upper airway diameter during expiration will expand. You know, the meaning that in the upper airway, the problem is inspiratory, while the problem in the lower airway will be expiratory. So that is the reason why we say upper and lower airway. And that's the reason why people invented thoracic inlet. It's an imaginary point between the pressure outside the airways at the atmosphere and inside the chest. Any question about the difference between upper and lower airway?
No.
Great. So let's move to respiratory effort. So respiratory effort increase when there is increased resistance. And remember, when we say resistance, mean airway. When we say compliance, we mean alveoli. So remember that. So when there is increased resistance, we get increased respiratory effort in the lower airway. When we get increased stiffness or decreased compliance, we get increased effort, such as pneumonia, edema, effusion. We also get increased work of breathing if we have accumulation of CO2 or accumulation of acidosis, and the lung is a compensatory mechanism, such as in DKA or salicylate ingestion or inborn error of metabolism. But also, we can have increased work of breathing when we have upper airway problem. How increased respiratory effort manifest? We have nasal flaring. What is nasal flaring? Anybody knows?
Abnormal movement of LNASI.
Yeah, so you'll start to see the LNASI moving, and usually you should not. Then you should start to see retraction, which is inward movement of the chest muscle, and this can be subcostal, substernal, intercostal. And it can be mild, such as you have supraclavicular, suprasternal, but it can be severe when the whole sternum starts to move. You can see the head also start to help. So you see head popping. And then you start to see seesaw respiration. So respiration goes up and down, up and down. That's mean in severe cases. And usually this is when there is obstruction or severe lung tissue disease, or you have a problem of controlling the breath, or what we call a disordered control of breathing. Also, when you have a neuromuscular disease or even muscular disease, or even sometime in fatigue. If we have a prolonged expiratory time, mean we have lower airway problem. If we have prolonged inspiratory time, we mean that we have upper airway problem. When we have difficulty in breathing, we can see open mouth breathing, and we can see gasping. And now we know what is gasping, right?
Yes.
Right.
Okay. And also we can see use of accessory muscle as we talked. And then we need to know what is grunting. Now, is anybody can tell me who never attended my lectures, what is grunting? Anybody knows what is grunting? Yes, you know?
Reverse respiratory, when we pause, not in end expiratory, but in end expiratory phase.
Oh, fantastic. Very good. So the grunting is trying to maintain PEEP, because you know that we have three types of PEEP. We have internal PEEP created by the patient. We have auto PEEP created by a pathological problem. And we have the applied PEEP that we apply. So we human being, we need less PEEP because we have fat in our lung. So our lung never collapse. So when we lose that fat, we need more PEEP. So the body trying to create PEEP. So because of the fat, we spend lots of our life relaxing without breathing, pausing. So when we do the pausing, we breathe in and then out, and then we pause. So we do like this. And then I can stop. And then breathe and pause long time, because I know I don't need much PEEP. When I start to lose the fat, I cannot do that. So I have to breathe out and then breathe in right away. So I will do like that. And then I pause while the air inside my chest. So I reverse my respiratory cycle. So I pause instead of after expiration, I pause after inspiration. So when we say grunting, it does not mean that we have a breathing difficulty. When we say grunting, that means we are losing the surfactant. And that's happened in RDS or adult RDS. So either RDS or ARDS. And the causes of ARDS are many, such as in trauma, burn, presence of aspiration inside the lung, lipoid pneumonia, inhalation of any inhaled substance, aromatic or fumes or whatever. So when we say grunting, we mean that we are not able to maintain PEEP due to our loss of surfactant or decreased surfactant or neutralization of surfactant. Is the grunting clear?
Yes. Yes.
Okay. Should I stop here? It's been 1 hour. Or I continue? Should I continue or stop?
I think you have to finish A, B, C, D, E, and then.
Oh, that will take 1 more hour.
I think 1 hour is enough for tonight.
Yeah, I mean, the reason why I go to these details, because when you know the details, you become like a driver. So you start to do the resuscitation and care, like you driving a car. You will never forget, and you will never have a problem. So you can see resuscitation is very complicated process. But because I fractionated to small pieces, and these pieces become simple, small, and then when you memorize these simple pieces, when you do the resuscitation, you can combine all this and you can do very complicated resuscitation scenario. Because once you assess the breathing, in addition to the respiratory effort, you need to start to recognize the sounds. So we have stridor, or the inspiratory sound, or it's our upper airway problem. Or we have wheezing, which is lower airway. Grunting, which means we're losing surfactant. Sisu, that means we have using the diaphragm, sisu breathing or irregular breathing or high capacity breath versus weak type of breath. Sisu breathing mean we start to use the diaphragm. Okay, so we finished with respiratory rate. We finished with respiratory effort. Now we are on chest expansion and airway movement. The chest has to expand in a way to achieve normal tidal volume of a child. You know, in the newborns, especially, they can need 3.5 to about 6, but in pediatric, they can achieve more tidal volume between 5 to 7 ml per kg. So that's one. There's a good tidal volume. Second, should be symmetrical on both sides. Third, when you assess the breathing, you should uncover the baby at all, including looking at the movement, especially if the patient below 1 year. When you look at the expansion, you need to say, is it inadequate expansion? Or is it asymmetrical or it's adequate? When it's inadequate, mean the baby or the child is having inadequate effort. Or it might be airway obstruction, or it might be atelectasis. or it might be pneumothorax, or it might be hemothorax, or it might be fluid, or there is meconium blood, or there is foreign body. So we have the respiratory rate, and then the effort, and then chest expansion. Finally, you have to listen to the breathing. When you listen, you have to listen at the axilla, and it should be on both sides. And then you listen to the stridor, usually upper airway, caused by foreign body, or by infection, or allergy, or congenital, or a medical procedure. Grunting, as we talked about it. Gurgling, means there is secretion. Wheezing, expiratory, lower airway obstruction. And crackles or rails fluid in the alveoli, or loss of air in the alveoli. It's equivalent to B lines in lung ultrasound. And remember that when you have no good chest expansion, the baby starts to have rapid breathing, because the minute ventilation depends on respiratory rate and the tidal volume. And so we have ineffective ventilation when you have lower respiratory rate, or we have small tidal volume, or when we have very fast breathing due to any problem that at the end also lead to very small tidal volume. Okay, so I think I should stop here and answer a few questions before I end the session, and we'll finish the session next time until we finish all this, because it's around, I think it's 270 slides. Any question?
I have a question.
Go ahead, please.
When we put a unit on mechanical ventilation, we usually start with P5 and above, of course, and pressure. When we use SIMV pressure control, we use pressure control 9, 10. So the tidal volume always high.
I did not get the question. So let's back off so I understand the question. So what is the mode?
SIMV pressure control.
So it's a pressure, no, the reverse. You have to say pressure control, SIMV.
SIMV, sorry.
Yes. So either volume control or pressure control.
Ventilator.
That's your strategy. Either pressure control or volume control. And then your mode is SIMV. Okay. So I understand this. Next.
Yes. So when we get high tidal volume,
okay,
we can't
you got high tidal volume. What do you mean high tidal volume? What is the tidal volume that you got?
It's more than 7 ml per kg.
So your measured tidal volume is 7.
More than 7. We can't go 7 or less.
So
you say now that in a unit it is enough for a unit. It's enough 3.5 to 5 ml per kg.
Per kg.
Per kg, yes, per kg.
Yeah. Yeah.
We can't get this small number, so we have theoretically
you
always
cannot get
expand.
You cannot get this small number in the ventilator.
Yes.
That means your ventilator is not for neonate. Very simple. You are using adult ventilator for neonate, and if you put a neonate on that ventilator, you actually are killing him. Because you cannot, I saw this in Iraq, all the hospitals, they use universal ventilator. And I wrote on it, these are a killing machine. These are not ventilators.
As I know that this ventilator can be used for children and adults.
Wrong. These are the companies faking that. So what they do is they use software to control that. What you need a hardware. You need the most important part of the ventilator is the expiratory valve. So for example, when use Dragar VN500, and we have Dragar VN. So the Dragar VN is neonatal because the expiratory valve are small and it can achieve a small tidal volume. And when the Drager V 500 or Evita 300, you can still change the software, but you have to replace the expiratory valve. So if you cannot replace the expiratory valve, you might able to use the ventilator, the children ventilator for babies more than 4 kilo. You know, I would accept it, but will not have a good result if you ventilate for a long time. But because 4 kilo and 5 kilo, you ventilate for a short time, then. But if you have like 4 kilo and you have diaphragmatic hernia, you cannot use it. That's one point, because you have to achieve small tidal. Not only that, that's not a problem. There is another problem. So imagine that you have a scale. You go to grocery and you have a scale. You want to weigh 2 kilograms, okay? And let's you have, if you go to the butcher to weigh meat, they will use a bigger scale because they want to weight. So in grocery, you weigh 1 kilo, 2 kilo, 3 kilo, 5, 6, maximum, 5 kilo. You won't do more than that. But when you weigh like watermelon or you weigh meat, you cannot use that. So what they use a weight to scale, weight here and weight here, and the weight will equilibrium. But if you are using a scale with electronic, you will face a problem, because when we measure any measurement, when we measure in the middle, this is the most accurate. So let's say your scale measure from 0 to 100. What is the most accurate measurement in this scale? If you have a scale from 0, can measure from 0 to 100 kilograms. What is the best number, the most accurate number that this scale can measure?
50.
50. So 51 and 94 will be less accurate.
Yes.
And the least accurate will be 1
0 and 100.
Yes. So when you use adult ventilator, usually they can achieve bigger volume. So 200 mil, 400 mil. So when the ventilator can measure 400 mil, the lower numbers have a huge margin of error. And that's a big problem here. Do you understand the problem?
Yes.
Yeah. So we cannot use adult ventilator and children ventilator with neonates. Simply, they will die. Because you will damage the lung. You will interfere with pulmonary circulation. So these ventilators.
What can we do for this problem? Because
wrong. They are wrong. You cannot use them. They won't survive. You cannot use them.
We lost many units.
I saw this in Iraq many times. When I talked, somebody was threatening me. They called me and I've written on this about the ventilators, and I saw that I don't want to mention the city because they will get upset, but I didn't see appropriate ventilator in Iraq. None, zero. There is only the Drager, the baby log, the small old ventilator. This is very good.
I don't
All
see
these new
ventilator.
ventilators are not good for. The new ventilator has to be, SLE 6000, Hamilton.
No, only I
Fabian.
We have only GE and Mackie.
GE are not for newborns, are
yes.
not for children.
No, now we use Mackie.
McKay, right?
McKay, yes, McKay.
McKay, but now, in McKay there is a neonatal designated ventilator, not the universal. If the ventilator can ventilate adult, it should not be used below 1 year. It will simply kill the child.
Dr. Yahya Belazahma.
This is the two problem. There is another problem because I don't want to spend time, but there is another big problem. There is no safety chamber. The ventilator has to be safety. So you have chamber A and chamber B, because if when you use your computer, right? Many times your window will fail because your monitor either using Linux or using Android or using Windows. These are the software that we use in the system. All these can fail. But if they fail and you don't have hardware preventive measure, then also the child will die. Because all these software can freeze, can mismatch. You have the technical communication problem between them. They don't talk to each other. The decoding between the hardware and software get problem. So if you don't have hardware safety, then you have a big problem. So the GE or Gelinar Electronic, it's a big fake from the company.
No, it's we don't use now.
And I have a big problem, and then I have to leave the hospital because here, and I don't want to mention the name of the hospital. They get mad because I told them this cannot be used, and the head of the unit was insisting, no, they can't. And that's a big problem when you speak with somebody who does not know that he does not know.
دكتور يحيى بلا زحمه، السلام عليكم.
عليكم السلام ورحمه الله.
احنا بالحله عندنا اجهزه هاير الماني، هي مال اليونيت اساسا، بيها نيونيتال فلو سنسر وكلش اكيوريت، حلو بالشغل، يعني صارنا نشتغل بها 3 سنين.
No. The question is, do you use it for adult or not? That's the question.
لا هي مال نيونيت، بس انا السؤال.
Okay, so what if it's a neonatally designated ventilator?
Yes,
it's okay.
Yes.
And if it's adult and you replace the expiratory valve for neonate, you still can use it. You understand the difference? You should have a hardware change, not a software. So you don't switch by software.
يس. سؤالي دكتور، احنا دائما لما نشد عليها طفل، لما تكون الريسبيراتوري ريت مالته عاليه اكثر من 80، دائما يعطينا الارم مالت انه المينت فنتيليشن كلش عالي. نحاول قدر الامكان نقلل البريشر. زين.
Your respiratory rate يا دكتور عمار, your respiratory rate in a human being should not exceed 60. 61 is not acceptable.
Yes.
So when the baby breathes 60, you have 2 options or 3 options actually. 1, change the mode. So when the baby breathes above 60, it will not be supported. That's 1. So if you are an SIMV, if you are an SIPBV, go to SIMV. That's 1. Second, sedate the baby so the baby will never breathe. Third, extubate the baby. So if the baby is, or you have 4th option, go to high frequency. So you cannot ventilate a baby with respiratory rate more than 60. You're causing many problems here. Either you're achieving very low tidal volume, you can achieve very high tidal volume, not tidal volume, sorry, minute ventilation, or you're causing damage to the lung. So you should not ventilate a baby more than 60.
يعني هو دكتور احنا مرات ننزل بالسبونتينس المانديتري سايكل اللي نعطيها بالاس اي ام في، مرات ننزل بها ل10 بير مينيت، وهو البيبي اللي ياخذ اكثر من 60، فلذلك النتيجه توصفه.
No, sorry, دكتور, you're mixing because I think you're mixing. Okay, so in SIMV you do not support the SIMV. You only support the mandatory. The spontaneous is not supported. If wait, let me explain to you. Ammar, let me explain to you. Ventilators like Sarah. As I know Sarah, I know the ventilation.
Yes.
Not only the ventilator, but I know all the machines. So if you are on SIMV, you're only giving mandatory. The spontaneous is not supported. However, to prevent baby exhaustion, you can add PSV. So the PSV is to support the non-supported breathing. So if you are on SIMV, you set the rate 30.
Yes.
And then you put the PIP. So if you put the PIP on 25, these 30 will be supported by 25 centimeter of water of PIP. If the baby breathing 60, the other 30 will not be supported. So if you add pressure support or PSV with the SIMV, if you put it 10, the non-supported of SIMV will be supported by 10.
Yes.
Does that make sense?
Yes.
Yeah,
هو دكتور النظام الاس اي ام في اساسا من نختاره هو اسمه اس اي ام في شارحه بريشر سبورت، فهو مباشره يطلب منك انه المانديتري سايكل ايش قد مالت البريشر كنترول والبريشر سبورت ايش قد يطلبه مباشره.
Okay, so if you wanted only SIMV, what you should do?
لا هو ما
make PSV 0.
بالضبط صحيح.
Yeah, so if you want only SIMV, make the PSV 0.
نعم.
Okay.
واحنا دكتور
and it's PSV SIMV because it's not a good ventilator.
Yes.
If it's a good ventilator, it won't give you only that option. Because the ventilator, the reason why they do it, because they want to make it cheap. The reason they make it because they have to put extra valves. And putting extra valve means extra money. And because the one who bought the machine does not know. That's the reason why when you buy the machine, you need to know what you're buying, like when you buy a car. Because if you want to buy a computer, laptop, you will say, I want the screen 10-inch, I want the RAM 8 giga, I want the VG card 250, I want the hard 1 tera, I want the motherboard 250, I want the processor Core U7 with 2.5 again. See, these are because you ask all, I need like 3 USB port, I need C port, I need memory slots, you know, you ask for whatever you ask. From this, the computer guy can give you one option to 400 options. Each one has 6-7 options. You got same in the ventilator. So they can play with you without know. So they can give you with a very good options, you know them. They can give you by 1,000, they can give you by $100,000. So you need to know what you buy. So the reason why it's SIMV, PSV together, because they are missing one of the valve, and they removing it, and it make about $10,000 difference. That is the reason, sir.
Yes. Thank you, Doctor.
Any more questions? But remember, if you have fast, give sedation. Huh? If you don't want, you should never ventilate baby more than 60. Any more questions? Sorry, the question not related to session, but I have to answer. Any more questions? Our colleagues, my friends from Kosovo, anybody has any question? No? Any question about today's session?
No, thank you.
Do you guys enjoy it? Should I continue the session about acute sick child?
Yes, of course.
Okay, great. So next will be Saturday, because some of you selected Friday, some of you selected Saturday. So we'll do next session Saturday. On Friday, I will give to the Libyan Society a session about neonatal resuscitation, because they asked me for that. But anybody want interested, then I also will give another session about management to the Saudi Arabia Neonatal Society. I will give 2 sessions. One is about the treatment of shock, and the other one, treatment of feeding and swallowing complications.
Okay, please send the link to us so we can join you.
We're waiting the signature for our society to be released, hopefully next week. There are lots of bureaucratic requirement, unrealistic, but we're working on it. Inshallah, we'll open next week, and then we'll start our website. So I'm also working on making a complete guidelines for neonatology and PICU. In NICU, we have 400 guidelines, and also I will make it also up. So for the society will be free, for others, they have to buy it. Okay?
Inshallah.
And you will have only username and account, and if you access it in more than one app, you will be blocked. So you will have one browsers and one app access, but if you access it more than one, then you will be blocked. So if you want to change, you have to call, and so hopefully it will be ready. I think I made right now about 15% of it, but I'm working on making a complete guidelines. We also will have our conference, and I hope that we can bring some of you outside for training. And when we do the conference, we will have a 3-location conference or 4 locations. So we'll make it in 4 places in Iraq. Hopefully in Basra, in Baghdad, in Erbil and Ramadi. So we have like a satellite conference. I hope that we can do it. I'm working with the conference organizer to make it in more than one spot. And I hope I can come to Iraq to be there, inshallah.
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 Any question? Okay, now when we start, we will invite other speakers, inshallah, not only me, but any one of you want to present, I can help. So if you want to do a presentation, even short one, a case presentation, a topic presentation, a problem you're facing, what is the problem and how we can solve it, all that we can work. So if you want to do a presentation, communicate with me privately and we will work on it. Okay?
Okay.
Okay.
Thank you very much, everybody. Enjoy the rest of your night.
Thank
Bye-bye.
you very much.